Record on this computer. Okay,
Yeah, I'm gonna start. I may as well. So Majid, is now a good time? I can do my
Yes,
intros.
go ahead, please. Yeah, please. Yeah, I'm ready. Yeah. I'll
Okay,
put my phone on
I'm
Sorry, I
silent.
just
Yeah.
have to interrupt. Did someone
yeah.
say nipple?
no,
No,
Whipple, Whipple,
Whipple,
Whipple.
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 Oh, well,
you're
actually, I mean, I'm
you're
not.
Wait,
I'm
alert to the
I
no.
was not
wrong words,
supervising
Richard.
Brad on his breast rotation, just
Well,
GI.
I'm not being the kind of guy you think I am. I'm just submitting a grant right now to use optical OCT to train dermatoscopy to image nipples during breastfeeding for women who have breastfeeding pain.
Oh, okay.
So,
Wow.
totally legit.
Yeah.
And I doubt if I'll see a nipple in the whole study. So, um,
Well,
other people will manage that part.
yeah.
Yeah, yeah,
All
interesting.
right. Well,
I
you're
hope
you're a man of many talents, Richard.
Including nipples, apparently.
This just adds to the list. Yeah.
good
Okay.
luck with that grant. Yeah,
Thank you.
that sounds interesting. Well, yeah. So, thank you all so much for joining today. I know we'll get some more speakers, so that's why I was going to do this first, sort of our intro, like I usually do. It's almost fall. Majid was telling me it's getting cooler in Alberta. And, thanks to everyone who come. We have a lot of regular, participants. And so I appreciate that and new people too. So that's good. And if you have any ideas for speakers or collaborations, we welcome that. We're going to have in 4 weeks, we're going to have a kind of a review and planning session. So stay tuned for that because we want to get ready for hopefully to join our friends in Alberta, um, you know, in October of 2026. So hopefully we'll have something to show at this meeting from this group. And maybe, hopefully even a paper after that. Probably not before, but hopefully the preparations for that, like we've done a couple of times. I want to, we won't meet the week of Kidney Week, and that's in a couple of weeks. And so I hope everyone there has a good time. Unfortunately, I can't make it this year, but I hope you have a good time who can go. And again, to review our, aims, image banks and repositories. I think a lot of trials are going on now and had developed images, and Dominique talked about that a little bit a couple weeks ago. So, I think that eventually those images will be good image banks, and so I think that's something to keep in mind. And then algorithms. Obviously, we've had the you know NIH grant that we collaborated on with Kitware, and then there are a lot of other algorithms out there. There are no official algorithms as far as I know yet, but other than I think the sort of iBox, but it doesn't really have a lot of image analysis. So I think that's something we need to contribute and think of ways to do that. And Dominique has that trial going on now, and also the competition. And if any of you are able to participate in that, contact her, and I can help you if you need her. I think it's almost too late though. She did extend the deadline, so I need to get on that honestly because I'm part of that. But if you're participating, please do. And then the last one is what Kim came up with one time is to rethink the innovation timeline. And so we need to continue to do that. Upcoming meetings, as I mentioned, will cancel for Kidney Week. So we'll next meet in 4 weeks, and that'll be a planning session. And then, Drew Williamson in early December will speak. He's someone here at Emory who's done amazing work with Faisal Mahmood at Harvard. If you remember Sharifa Sahai, she was part of that group. And so he does amazing work and is doing that here at Emory. And then we'll have a couple of breaks for the holiday season and Happy New Year. And then we'll meet the middle of January. And probably that'll be another planning session, but I'm still working on that and meetings after I'm still working on. So if you have any ideas or if you want to speak, please let me know. But I think now, Majid at Alberta, I'm going to turn over to him. I've heard him speak before, and he does amazing work. there in Alberta on kidney transplant rejection. I know a lot of his is molecular, but I think of anything as being digital pathology, honestly. I don't have a strict definition for that. We've debated that before in this group, but I think of anything being that almost. And I think that his research really helps inform some things that we could do here. So I really look forward to his talk. And thank you so much for speaking to Majid. And I'm going to turn it over to you.
Sure. No problem.
Thanks a lot.
Share the screen. And there we go. See my screen?
Yes.
Yes, you can put
Okay,
it.
I'll
Yeah,
start. Oh, no, keep cap. Oh,
presentation. Yeah. Oh, there you go.
yep.
Good. That's good. Thank you.
Perfect. Okay. So, yeah, thank you everyone for having me, and thank you for letting me into the group. I think I'm one of the few non-pathologists in this, and I've learned a lot from you guys. One of my mentors is actually Dr. Kim, and we hang out a lot. I usually bug him a lot during the rounds. Lynn has probably heard us. But I did a master's with Dr. Phil Halloran, who I think everyone knows, who does a lot of work with microRNA analysis. But me as a clinician, I wanted to try and get a more clinical context to the pathology. You guys do great work. You got excellent pattern recognition, and you give us concrete diagnosis. But the struggle I had is how to kind of translate that to a patient. I mean, we just walk into a room and say, hey, we have rejection, we have to do 1, 2, 3. And to be honest, as we all know, the treatments are not very good or standardized. And where they end up in Calgary, Alberta, the way things are handled are very different. And we don't actually follow things up among ourselves to see what is better and what is worse. But there are ongoing trials trying to kind of consolidate that. I think one thing that helps us explain things to patients is if we put it in a probabilistic type of way, they tend to understand it better. So my work, basically, I developed models of the IntercomX database, which is a database that was used for training the MMDX method. But within this, it was an indication biopsy, mostly, I think over 95% were indication biopsies versus other databases in Europe and so forth that are protocol biopsies. So kind of a different subset. And I think that's more pragmatic because in our center, we only do indication biopsies. We don't do protocol, but we'll discuss that. So this picture here kind of tries to integrate everything, pathologists, clinicians, and outcomes of interest. So I'm just going to try and link everything in a way, and I'm not pushing my models. I'm just trying to push a concept of a probabilistic approach. And there's a lot of good work out there, which I think has been shelved, which I think we should try and integrate in kind of translating this to patients. Yeah. So as we all know, the BAM thresholds basically look at lesion scores and kind of try and put them through a score between 0 and 3 with lesion scales with some clinical context. With this, I feel basically this is a snapshot or cross-sectional look at a biopsy, but it's as we all know, rejection is a continuous process. And we've tried to put them into discrete thresholds, which I think has its disadvantages. But I think pathologists have a very good threshold at looking at this. That's why you might find more experienced pathologists can recognize things that less experienced pathologists can, and kind of put everything together and give a diagnosis which tends to be better than others. And I think for some of us who are lucky with very experienced pathologists, we don't have much of a problem. But I'm thinking about where I worked and where I trained previously in East Africa, where pathologists don't have a lot of experience and don't know how to basically put everything together. So this is kind of something to help them and also help the clinicians understand, especially in low output centers that don't do many transplants. And a lot of our fellows come from developing countries where they do 30, 40 transplants a year. So these are type of models that could assist them and their pathologists in low output settings. And I'll put it this way: where I trained, we could do a biopsy, but to get immunofluorescence and further testing, these things had to be sent out of a continent or to another country to get done. So it could be weeks before you get a full pathology report. So when I was doing some of these models, I was trying to kind of come up with probabilities without some of these available tests, which might take time. And also, I feel that these could be used to track outcomes, and I'll explain why. Please feel free to stop me if you don't understand anything. Keep it totally interactive. I don't like monologuing for a whole hour. Yeah. Okay. So, all right. So I think this is currently a current practice. I'm not sure if you can see my mouse. So I think this is kind of what we do. We get biopsy features and other variables like C4D, DSA. We go through the BAMF rules and basically come to a diagnosis. And this is what we do every day. I just want to highlight this. There is a bit of DSA gating, which might hide biological similar cases. For example, the new concept or relatively recent concept of DSA negative ABMR and so forth has been understood. So things are developing, but I think there are other ways we can move quicker and better. I also want to bring this to a forefront, some work which is done, which has also helped kind of make things a bit better. I'm not sure how many people actually use it, the BAMF automation system, AutoBAMF. Dr. Hadran actually had in-house a small one for his database. I think since early 2000s, it's actually helped kind of standardize the BAMF out calls when we were making our models. But we used the pathology out calls for purposes of our study. What I think the future may look like, and this can be integrated with multiple things, and it allows for AI and everything to come in, because they're models and they're totally adjustable depending on what information you have. As long as you have what you consider reliable information and closest to the truth, we can use that to develop models. So in my study, this is kind of how it looks like. You have your biopsy features, other variables, and you can add GFR, DSA, time post-transplant. You punch them into the models and it'll give you probabilities. So an output would look like this. So the overall probability of rejection will be 0.9, probability of TCMR 0.12, and probability of ABMR or AMR, depending where you're from, is 0.3. So it'll give you the level of certainty or uncertainty with variables. And you don't need all variables there. Of course, the more you have, the better. But it can give you certainty, and I'll give you scenarios where I think it can help. So this is the abstract, visual abstract for my study, and we'll go through it and other studies that kind of did similar things. So I took 167 indication biopsies for the InterComX study, which had most information which will be available from biopsies, lesion score, C4D, DSA status, and we developed regression models trained on the output of the MMDX signouts and using the recorded BAMF scores. So we made two models, and I'll go through them, and we looked at the relative importance of the lesion scores, not in BAMF, but within our algorithm. So I think some people, when I present this, feel that I'm saying these lesions are more important than others. It's the weighting of the lesion within my model. And overall, we saw that the models within our database for an indication biopsy had reasonably good AUCs compared to BAMF at predicting MMDX, but most of the time there's agreement. And also with this data, we're able to look at survival predictions, and I'll show you how we did that. So this is just, I know it looks like a messy mathematical thing and it's probably bringing some trauma to some people, but what we have here is my models. So they're pretty easy to use. I know it looks quite messy, but it's something that anyone can use, as long as you have a calculator and you can read the lesion scores reliably. So you just, for example, the TCMR model 1, you can, and just by, if you, I don't know, those of you who have done logistic regression, so you have this is the intercept. This is the G scores. You put it as you call it, PTC, CG. If it's positive, it's increasing the probability of that outcome, which is TCMR. If it's negative, it pushes against the probability. Time is a bit complex because the time relationship is not linear, and I'll show you a graph explaining that. So I ran two models kind of trying to run through scenarios. So usually when Dr. Solis is on call, I bug him at like weird hours saying, I've got a biopsy, I need an initial read today. But I know with that initial read, I will not have C4Ds, I'll not have DSAs, the lab is running them, and a whole bunch of other information. So I kind of tried to make models where though that information will not be available, and try to see if that would still give a reasonable prediction on a time constraint biopsy. So I could say, Dr. Kim Solis, if he punched it in, could say, hey, listen, with with the absence of C4D, DSA, and so forth, this still looks like the probability of ABMR of being 0.8%. And you can set the threshold for what you'd consider definite rejection. And this can be shifted from center to center depending on the training that you do. So when we looked at the variables that were necessary or important for the models, so I did two methods. I did logistic regression with and without those variables that take time to come out. And we went through, and this is the importance, not in BAMF, but in my models in terms of how these weighted towards probability of a diagnosis. So if no surprise for ABMR, or mixed rejection, because the way I kind of did the equations was G lesions, PTC, then CG, then I. Log of the time post-transplant does weight reasonably heavily, more than the other clinical variables. So time is something we all know when we get the biopsy. You know when the patient was transplanted. These are the things we don't know. And other lesions in the model didn't push as much for the diagnosis. For TCMR, surprisingly not, TI, time featured quite significantly. GV, some of these are negative, some are positive contribution, and or no surprise, C4D, DSA, and so forth didn't push so much in TCMR. So I ran these with and without the clinical models to see how they did, and the arrangement didn't change that much. I also did a similar, but now running with random forest models. And overall, there was some slight difference, but kind of mirrored each other, just kind of make sure that there was no significant discrepancy. We used ANOVA for this, and we did a random forest for this. At the same time, when I was doing this work, I think the Belgium group, if I'm not mistaken, came out with this paper, and they used machine learning and XBoost, and kind of very similar if you look. So the ABMR model kind of almost mirrored us with G lesions, PTC. They used other clinical variables such as serum creatinine and urine protein in terms of trying to predict ABMR. But this was interesting. But their database was a protocol biopsy database, but they validated in other two databases, but very similar. And I'll talk because they actually kind of externally validated my equations in a study that's coming out in the next few months in Nature. So I'll speak very briefly about that. I've seen some of it, but I think I'll let them publish it. I think we should probably invite them for a talk if possible. They've done some very interesting work. So this kind of gave me a sigh of relief when I saw this paper coming out just before I sent mine, because it kind of aligned with what we were saying. Now, I previously mentioned time with rejection. As I mentioned, time is something that we all know about when we get the biopsy, but what's the relation? So this is from the Intercomax study, and when we look at the relation of time, it's not linear, as I mentioned, and that's why in the equation there were two time entries depending on before and after, and it's not too hard to punch in, but we've totally automated it, so you don't have to worry about that. So if you look in terms of TCMR, the peak of TCMR in most patients in the database for indication biopsies was around 1 year. Then after that, it tapered off. And from a clinical perspective, I can totally explain this personally, or kind of have my hypotheses. Some places or a lot of clinicians at 1 year tend to taper off or change tacrolimus targets and so forth. So that's when anytime you have immunosuppression down titration, the chance of TCMR go up. Also, effects of drugs like thymoglobulin for induction have been shown to wean are approximately 8 to 10 months. So maybe that could also be a relation depending what induction agent you use, especially in the US. I think over 50-60% use thymoglobulin versus us in Alberta. It's in our center, it's totally skewed the other way. So it's interesting to look at our own subset and see if it follows the same relation of whether induction matters. So it's mostly clinical factors and clinical changing of issues that cause this uppeak in TCMR. For ABMR, now you can see it's later on, and this tend to be patient-related factors. So medication non-adherence. As time goes on, monitoring decreases. As we know, instead of seeing the patient every month, we see them every 3 months, every 6 months, depending. And unfortunately, not seeing us sometimes leads to bad things happening. So yeah, so I think a lot of pathologists know this. Usually when I'm having discussion with Dr. Banosis, Dr. Kim Soles, I'll tell them, this patient, haven't seen this patient for 6-7 months, they've disappeared, they showed up again. I think the one taking their meds. And this, we kind of goes into the mind of the pathologist when you're looking at things, I assume. Tell me if I'm wrong. But these are things we kind of gestalt and know about, but I've tried to quantify that into the equation. I think that's where the experience of pathologist comes in versus a non-experienced pathologist or reader. They might not have that context that you guys have, especially in low output centers. Then I kind of looked at what is the effect of adding those clinical variables between both models, just to make sure that there was no significant difference. For example, if I said I'm removing C4D, DSA, and PRA, would this affect the model so much that I could say that its output was not reliable? So for TCMR, the addition or non-addition of these things didn't really matter. So TCMR does, as we all know, is not antibody mediated, so that doesn't matter. For ABMR, having the information was helpful, so they were slightly better, but we still felt the overall AUC without them was still reasonable. Then looking at the only clinical variable we added, but we could have added more, was time, and time improved the models significantly at all instances. So adding time to these models or to a prediction of transplant rejection is helpful. Also, at the previous study I showed that around the same time showed that also adding these increased the accuracy and clinical integration, also improved survival stratification. So for now, most pathology reports will just give a diagnosis, but with models, we can look back at the database and see how similar kidneys with similar lesion scores or similar probabilities did, and kind of help inform the clinician. And I'll show you how we can do that possibly. This is just statistical jargon to make myself feel better. Nice graphs. So AUCs were reasonable for all the models. We had initially in the background just a rejection or rejection model. It's kind of fitted in the back, but there's no specific equation for it. And I compared this with the AUCs from at the same time from a slightly different method from the XBoost, and it was better. So the general pattern was adding clinical variables seemed to make the BAMF diagnosis better in prediction. And one thing that we did when we were sub-analyzing our database was there were some biopsies that had lesion scores, but were at the end, the call out was no rejection. Our model called out rejection. So we're kind of curious, like, okay, pathology said no rejection. So we looked at these kidneys and tried to look at them and see how they did, because they were called no rejection. So if a pathology tells me there's no rejection, I'm less inclined to do something, but maybe they had a T or an I or something. So the biopsies that were called rejection by our models, the kidneys did much worse. So that kind of gave us a red flag in about 600 kidneys where this scenario happened from the database. So we said, okay, why would the pathology say no rejection? So some instances we know BK, right? If you see inclusion bodies or SV40 and certain lesions which BK can mimic rejection, maybe that was it. So we removed all the ones that were called BK and left which were not much. And still there was a bit of, not a bit, there was a difference in those. So just using the same data and coming to a different diagnosis, we could see there was a difference in outcomes. And maybe that's where we can help. Yes, maybe it's not rejection, maybe it was something else. So maybe these biopsies could be flagged as biopsies of concern and maybe trigger further testing, reflex testing for further tests that's going on. So I'm just trying to get to the truth, and these are the situations that we don't want for our patients. And in terms of predicting outcome, well, this wasn't published. This was in our supplementary data. We looked at the lesions that were predictive of 3-year survival, and I think most of these are not surprising. So CG lesions, eye lesions, having antibodies, not necessarily DSA, and also the time post biopsy and so forth. And also just histologic call out of rejection was also prognostic, unsurprisingly. So these in the background can be used for predicting outcomes. Now, when we looked at how models did versus BAMF at predicting, they did reasonably well. There was significant agreement between both methods. yeah, our TSMR models did slightly better than our ABMR models, which I also saw with the other group. So this is how the output would look like. We did a little shiny app. It's not publicly available, but I just used it for demonstration, but it's something I can discuss with the team on a trial basis. So you'd put in as a pathologist, or sometimes clinicians, you can put them in as long as you have a reasonable call out. You put your IITV and other lesions in, and you also put in post-transplant days, and you can add more information, but we can actually look at and see if that information is helpful. So what it does, it'll give you a probability, so probability of TCMR, probability of ABMR, just the overall probability of rejection. So it gives you these three outputs, so estimated probabilities. And as I said, you can set the threshold depending on your center. You can say if it's above 0.4, then it's definitely rejection. But of course, the higher the probability, closer to 1, the more definite or the more certain you are. And you can say there's a 20% uncertainty it's not rejection. So it's a good way of quantifying using the lesion scores as a diagnosis. Another thing we can do is look at the biopsy in relation to its time, its space among the database. So you look at this little triangle here. This is the biopsy, the index biopsy. Then it looks at the other biopsies in the database and where this lies. So you can see tends to TCMR tends to come to the bottom here. This is principal component analysis. Then ABMR here with normal, but if it was here, it would be totally normal and mixed in between. And the thing is, you don't have to, this was using MMDX callouts. You can also use histology callouts in the principal component analysis. So whichever way you want to look at it in the system, and you can also compare it to the lesion scores closest to it. This is just a kind of closer image. So here's another one we ran. So this biopsy had a high probability of ABMR. As you can see, it's kind of clustered the ABMR just on. So you can just do it on the biopsies with similar lesion scores where it's at. Then you can actually look at these biopsies, its closest neighbors, and see how they did in the long term in terms of survival. So you could say this biopsy has got a 0.9% of ABMR, and looking at its closest neighbors in terms of multiple variables, these kidneys lasted 10 years, 5 years. But that's, of course, with caveats, right? But we don't have data on what treatment they got. So that would be, if you had more granular treatment, then you can say biopsies that look like this, time post-transplant, when they got this regime, they did this. That's what I think in my future. That's not kind of clinical advice from the pathologist, but kind of the available information we have with the data we have.
Majid, I have a quick question.
Yeah, go ahead.
Looks like no rejection everywhere. Why is that?
Yeah, with this one I used, sorry, I didn't have the thing. We used the BAMF callouts. So I used the BAMF callouts. So there were some BAMF diagnoses which got no rejection. I'll bring better ones. Yeah, so rejection, there were some patients who had lesion scores who were called no rejection. When we looked at those ones, when I ran my database, the background is the database and what they were called. This is my call out for my probability. Say my probability is like most probably like ABMR. If I switched it to MMDX, you would get the MMDX callouts. So this might not MMDX might have said this is ABMR. Okay, so this is it's kind of mixed. Sorry, I should have kind of put better baggage. Yeah, you get it. Yeah, this was the BAMF callouts. Most of the time they correspond. 99% of the time they correspond, but then you get these ones. In the program, if you look here, I could have switched between MMDX and histologies. This one was MMDX. Then you can switch to histology. They will change slightly. So that's it. Yeah.
Yes.
We're good. Yeah.
And
then
I'm sorry. Oh, sorry.
Yeah, go ahead.
I had a quick questions. Yeah, this is great. Really interesting.
Yeah.
So what is the lowercase p ABMR and
if you look at the MMDX callouts, there's a probable.
okay,
probable ABMR,
probable. Okay,
like
okay.
borderline type. Yeah. Yeah.
Oh, border. Oh, okay.
Yeah,
Okay.
kind of. Yeah.
So,
Yeah. Similar to what you consider
oh,
borderline. Yeah.
okay. Okay. Yeah.
Yeah.
And
And
yeah. Huh.
yes, Brad, go ahead.
Oh, yeah. It's interesting. Yeah. Well, I was
Yeah.
wondering, so yeah, I probably missed something here. So what's the overall gold standard? I mean, like, so you have,
Yes. Yes. That's a good
yeah.
question. Yeah. So it depends how you want to do it. And the way I did it, I used my gold standard as the MMDX callout. That's the one I trained my models at. But you could train your models on BAMF, but it's good to have a comparator. So you could use whatever method you have, as long as you have a database, and train it against that, or you could train it against expert panel, right? You could have an expert panel of pathologists who sit down and go through thousands, which you guys do, and you could say that's the truth and train on that. So there's many ways to skin this cat, literally. So you don't have to do it the way I did it, but this, as long as you have the data, you could do this. Yeah.
And so the MMDX, I know when Dr. Halloran, first
Yeah.
established that, it was basically based on, Dr.
Yeah.
Soles and
Yeah.
Michael Mingle
Exactly.
and Tim Soles and so, what they called it. So essentially they were what MMDX initially first,
Consider truth. Yeah.
yeah, they were
Consider
the
truth. Yeah.
ground truth, weren't they?
Yeah.
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 Mhm.
So I know it kind of seems circular in that sense, and I got those comments when we're getting reviewed. It kind of seems circular, but the way MMDX now, initially the training, but now it's also got unsupervised training. So later on, the more biopsies it got, the more training it got. It kind of starts. It kind of learns itself. It starts learning to do it itself, but it does need a truth to learn of. So as I said, most of the time there is agreement, but I think the biggest problem is when there's no agreement, right? So that's the problem. That's when we need integration. And I kind of, in my mind, that's where I want to bring this together. When there's no agreement, when it looks like TCMR, everyone's happy. I mean, not everyone's happy, patients not happy, but then we can. But the issue is when there's lack of data. For example, when I'm sitting there waiting for DSA, as I mentioned, in some countries you have to wait weeks for DSA, you have to wait weeks for C4D, you have to wait weeks. So at least you can say, hey, listen, with the information I have, the probability of rejection, because you can't make some certain callouts, is this, pending further information. If it looks quite certain, it's quite certain.
And
So
presumably now with I'm sorry to keep interrupting, but one last
yeah,
comment.
go ahead. Yeah,
Presumably now, since your study is based on intercomics, there are more pathologists that have fed into the
yeah,
database.
exactly. Yeah,
And also, so it's international now more.
yes,
And
yeah,
also, but I wonder the next step might be like an ensemble diagnosis, like combining
exactly.
nanostring and MMDX and maybe other molecular. And then
Yes,
ultimately, I think that MMDX is very expensive. So finding
yeah,
a few markers. I know that's the key I know
yes,
like
yeah,
Candace Rufus has done that and other people have done like a subset of markers that are really still, and also
yeah.
I know several people have worked on that. So yeah, so I guess that's sort of where it's going now.
Okay. All right. Yeah, and that's totally right. Like I said, as I said, I'm not pushing my models. I'm trying to push a concept. I'm not trying to do a revolution. I'm just going to get evolution in the way we look at diagnosis. So basically what we've tried to do is try to convert the discrete variables into continuous variables. And I think this has been done. iBox kind of does that. If you look at the protocol biopsies when I was on a few weeks ago, these scores, I don't want to kill the names, those kind of convert into a continuous scale. And as I mentioned, this is coming up, and the Leuven group, I'm probably saying that wrong, took my equations and they run it through their database, which was a protocol biopsy database, and they actually performed. My TCRMR model did better actually in their database. So I was actually impressed. So that was kind of our external validation. It has not been published, but they're publishing a paper soon where they're converting to continuous indices, and it's actually quite good work. And it's still using lesion scores, but kind of trying to convert them into continuous variables, and they can predict outcomes. So in a subset, they actually used my equation, so it kind of validated it, and they performed quite reasonably well. So they did some work for me. So I'm thankful to them. So it should be out in press soon, I think in Nature, if I'm not mistaken. So I think for clinicians, end users, is It gives probability-based outputs that translate histological findings into actionable risks, supporting individualized decisions and immunosuppression, and also maybe those biopsies where we saw they were not totally normal, but were called no rejection. And if the model says there's a high probability, that might further push the clinician to either watch closely or change management, and not just say, okay, it's not rejection, I'm not going to do anything, but kind of flag, yes, but by BAMF, there's no rejection, but the biopsies that look like this, according to the database, things didn't go well. Please correlate clinically, and that might trigger further testing or reflex testing. And from multiple studies been shown, integration of clinical data does improve discrimination and aligns histological probability with graft outcomes, enhances prediction of graft loss. And also, I think what I want to see is response to therapy. So like if your biopsy looks like this and similar biopsies look like that, and they got X treatment, they seem to do like this. From a clinical perspective, that's important to me. It might not mean I'm going to follow that as gospel, but it kind of helps me when I'm having discussions with patients, because sometimes we don't really know the truth, but I should present as much information and we come to a consensus with the patient. And also, it's a scalable way of monitoring disease activity longitudinally. So if you repeat a biopsy and the overall rejection probability is decreasing, it's a continuous variable. You can actually quantify like things are getting better. So I know some places do post biopsy. If there was a rejection, they do follow-up biopsies in 2, 3, 4 weeks, depending on your protocols. And you can use this for tracking, also for tracking response to treatment, whichever method you use. And also it will support outcome-based trials. As I mentioned, I think it can be used for real-time decision support. So especially when I'm pressing and bugging you guys for a diagnosis, oh, what is it? What does it tell me now? Which you can't sometimes for obvious reasons. You could give me a say, hey, Majid, this, given what I'm seeing, the probability of TCMR is borderline, blah, 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 and that will kind of maybe calm me down. Probably not, but anyway. Then also you can also have a model-driven reflex testing. So for example, if you do a biopsy and it clearly looks like rejection, TCMR, you may not go through the whole thing and say, hey, listen, given the information I have, I think this is very likely to be rejection. But the problem comes with borderline cases. This might say, okay, this is kind of borderline. We need to do more testing. So whatever testing that may be available to you, like what you mentioned, Brad, some other stuff, cheaper tests, cell-free DNA, do you want to be doing these other tests, right? These are expensive tests, so you don't want to just do them for every patient. So some of these borderline cases may cause reflex testing and allow you to come to better diagnosis. So that's what I'm thinking. Might be also potentially cost saving in the long term if we have enough data and say if the scale is at this level, we're sure enough we don't need further testing, or if it's borderline, we should reflex to this. So that can maybe save some testing. But that's up. I think that will be a more individualized type of scenario. And also for research, I mentioned before, for training benchmarks and quality assurance, you can help translate between centers and try and I think in the future, once you have a lot of data, we can do in silico trials where you run model-driven rejection probabilities with surrogate endpoints from multiple centers, and you can actually come up with recommendations. I think AI can help with this. And I think computers will do better with continuous type of variables, and you can make prognostic engines. Because with my discussions with patients, when I tell them, yes, you have rejection, the question they always ask, how long is my kidney going to last now? So a lot of times I can't tell them definitely, but now I could say, listen, kidneys that looked very similar to yours with this treatment, with this GFR, with this lasted an extra 10 years, or they lasted 2 years, so that will make our total decision making very different. Okay, because currently I just tell them, I'm not sure, let's see how things go. So maybe I can add some nuance to those discussions. Okay. Yeah, I think this kind of continuation from what I've said. Yeah, and this kind of, I was running a timeline of how things would go. I'll talk to within our own centers, a few pilot centers, to come up with their own scores, or we can help them make them, depending on the database you have, or can use mine. That mine are publicly available, so you could use them, and we could go forward. So just yeah, that's the end. So any questions?
Oh, I mean, that was really great. I mean, I have a lot
Yeah.
I could say, because it really made me think about things, but I want to let other people go first. So any comments first? Okay, Richard.
I have a comment question. That was wonderful, and sort of remarkably aligns with some of the stuff that's been thrust on me recently. Just a wee update. I've been, some of you may know, I've been appointed to the board of the Digital Pathology Association, and as part of that, I've also been landed with two responsibilities. One is global outreach, and the other is patient engagement. And the whole notion of pathologists being involved in engaging directly with patients, creating patient-sensitive or responsive reports, and actually talking directly to them is something that's, I think, become much more in the mix. And the other thing is the global outreach is, we don't have a lot of experience with foreign, low resource settings. And so that's, we're trying to reach out and engage with that. And it sounds like you're right in the middle of both of those things. And I guess would encourage you to join our efforts.
Yeah, thank you. Yeah, I think I just want to make this accessible because I mean, when I get a biopsy from Kim Soles or from Brad, these guys look at hundreds per year, so I trust them. But a pathologist, not that I don't trust them, who sees 10 or 20 a year, that's a different scenario. If we can help them translate things better, I think that's what we want. Yeah.
So your timeline naturally interests me.
Yeah.
And you're not the only one creating them. Paul Keown, for his Genome Canada grant that he's currently applying for, automating pathology reading of kidney transplant biopsies is high up on the list.
Yeah.
But automating is of no value if it's done the wrong way, right?
Yeah, exactly. Yeah. Garbage, I mean, garbage in, garbage out. Yeah.
Yeah. There are strong political winds blowing from many points of view to standardize all kidney transplant biopsies across Canada and then across the world, So, but I want to make sure that we allow a lot of input into that rather than just picking one narrow system and having it govern how the automation. That would be one way to ensure that kidney transplant pathologists are replaced by robots quickly if we do it wrong, right? And if we keep the human element, then I think we would end up with much better quality. Yeah. So
yeah, and there's always something that a machine can't replace. As I mentioned, if you look, and even in the equations you can see it, there's an element that we can't usually quantify, and that's probably the gestalt and the experience of the pathologist calling in the call out, right? We can't quantify that, but I can quantify the uncertainty. That's what I can say, this and this, but there's this amount, and that's what you can see with protocol biopsies and indication there will be a difference. And we could actually do a study just on that. I mean, it might not be clinically translatable, but it'll be interesting. Yeah.
Yeah. So Paul Keown's grant, I'm a part of it, but we don't know if it'll be funded. So anyway, we'll see. It's 26 million though. So
Wow.
It's substantial. Yeah.
Look, wow, that's amazing. I hope it gets funded.
Yeah. So
Yeah.
Yeah, Dr. Zhang, go ahead, please.
It's very impressive job. Yeah, I have a question regarding the model. So in the model, I want to know what's your a base for diagnosis, TCMR, ABMR is based on a BAF score?
Oh,
So ground truth? Yeah.
The ground truth for my equations was the MMDX callout.
MMDX callout.
Yeah. So the sign out by the MMDX. So that was the truth I used for my model. So in true sense, my model is giving the probability of molecular rejection by MMDX. So that's a probability, but you could make a model the other way, depending what method you use. You could use BAM for the truth, but then you have to do it slightly differently. Basically, what I'm saying is we can do this, we can skin this multiple ways. It just depends what you want to call truth and not truth. So, but for my study, it was MMDX.
Yes, I have another question. So, is possible to as for the like a TCMR, there's like different grade, like a borderline and like a 1A, 1B, such as such. Is possible to using your like a continuous variable to grade the level of TCMR or like ABMR to
Yes, yeah, we could do that because if for example, using MMDX, if you look at, I don't know if you've seen the report, it actually gives you continuous indices for each of these, so we could actually translate those. But funny enough, the Belgium group in that paper, which is coming out, they're actually doing that. So they've done something similar where they can grade it like a continuous variable, like severity type of thing. Yes.
Okay, great.
So
Yeah.
it can be done by multiple methods. We could potentially do that
Yeah. That's
because
big.
yeah.
Right. Like determine the severity. Yeah.
Exactly. Yeah. Yes, Lynn.
Okay, great. Thank you. Yeah.
Lynn Cornell has a question.
Yeah, little hands up. Yep.
Hi, thanks for this nice presentation. I appreciate your motivation behind it too, to try to come up with a model for, when you don't have all the information, which is a common problem, everywhere, not just
Everywhere.
in developing countries or under-resourced areas.
Yeah.
But my question is, and I was thinking about this more because I had just met a renal pathology fellow who's from Zambia and is going back there. And he was talking about, how they're, training a couple of renal pathologists to go to, who are from Zambia are going back. And my question for you is, what is the ultimate goal here? Is it to provide, I mean, of course, we can provide more information when we don't have all the information. But on the other hand, I think the ultimate goal should be to provide those resources to those other places, like train renal pathologists so they can go and have a C4D stain available and everything,
Exactly.
and have DSA testing where you don't have to send it to another continent to get the results.
Yeah.
So, I mean, I think that we also need to be working towards that goal, but also how can the BAMF schema accommodate these under-resourced situations, I guess.
Yeah, totally. I think, from a resource resource limited setting, that it makes sense. But I've lived those places. I've lived the truth in those places, and if it could be a number of years before they get to that point. And I've lived in probably in most of Southern Africa, and there are very few countries that are close to being able to reach what we can do here. So it could be another 10 years plus. And by that time, we will probably have moved on to something else. So unfortunately, these places are lagging behind, and hopefully, I don't know what the answer. That's mostly a social type of question. But I think from our perspective, how I think it can help us in our resource-rich setting, and I put quotations, is we could provide to the patient more information, like in terms of prognostication, looking at the biopsies similar to this from a database, looking at response to treatment. So biopsies at 4 years out that had similar lesions, and as Dr. Zhang said, intensity of TCMR, intensity of ABMR, they did this way. So when a patient asks me, so what's going to happen, I can give them, look, similar biopsy, similar situations, this happened. Currently, I can't really do that with any certainty. At least that I can give them some probability and some certainty. So I think it's kind of trying to bring the patient into it. As you've seen in Alberta now, patients have access. Like I do biopsies. I'm having clinic in the next 10 minutes. Patients will come, have already read up their biopsies before they've seen me. So, and they've started going down some Google rabbit hole. So, yeah. So I think it also helped inform my discussions on the other end.
Great.
Did I answer your question or left more questions for you, Lynn?
This has been Great. One thing I thought of is like, I think like Mark Haas, for example, is coming up with this thing where we need to have like an activity and chronicity index like lupus for
Exactly.
BAMF. But when he puts like in sort of and I think he has some, I haven't read all these papers. I can't even read all of his papers, but like, I think, he puts like an integer for like, for example, C4D cases with C4D or worse. So like put an integer
Yeah.
of 2, but yours is more accurate. I mean, obviously you have a lot more data behind your coefficients on the regression.
Yeah.
So I think, I wonder eventually how we would eventually be able to give pathologists that degree of
Yeah.
accuracy like
Certainty.
that.
Yeah.
Yeah,
Yeah.
exactly. Yeah.
Yeah. So I think, yeah, and this is the age of big data. We just have to know what to do with it, right? So yeah.
Yeah.
Okay. So
Wow.
yeah. Again, thank you for having me. Hopefully, I don't know. Hopefully, as I said, I'm not trying to push my methods. I'm just trying to push an overarching type of philosophy, which, from a clinical perspective, because I think we can help improve, especially discussions with patients, and because there's a lot of anxiety with the amount of information they get, and sometimes my answer is I don't know, and at least I want to be able to tell them something, and yeah, and this is kind of trying to translate from you. Yeah,
Wow. Yeah. Well,
yeah,
this has been great. I really appreciate your doing this, and I
yeah,
admire your work a
yeah.
lot.
Thank you very much. Yeah. Okay.
Yeah.
And yeah, I'll probably bug Kim Solas and try and do something. We'll see.
Cool.
Yeah. All
Yeah.
right.
Okay. Great. Well, thank you so much. Yeah.
Thank
Yeah.
you.
Lynn had a
Yeah.
great point about the integer making it easier for pathologists, which is
Yeah.
true. Yeah.
Yeah, it's true.
I agree
Yeah.
with her. Yeah. Yeah.
Mhm.
Yeah. Because, yeah, your method is great. Yeah. So
Yeah.
thank you so much. We'll let you get to clinic.
Okay. Thank you very much. Yeah.
Thanks
Okay.
again. Okay. Take care.
Bye.
Everybody have a good
Yeah.
day. Thanks a lot.
Bye all.
Bye.